is hypertensive crisis and hypertensive emergencies. Sorry, hypertensive crisis and resistant hypertension. That's the first topic. And then later in the afternoon, for the second session, we're going to be talking about the acute management of stroke. And for that, we'll be having our consultant neurologist, Dr. Kennedy, to be joining us at that time. So this afternoon, I'm Dr. Awofisoye. I'm here with Dr. Olalekan, consultant physician and cardiologist. Dr. Olalekan, good afternoon, sir. Thank you for having me. Okay. And thanks to our participants for joining and waiting for us to start. Absolutely. So this afternoon, we'll try to make it as participative and as informative as possible, and in a way that is easy to flow along with. We should remember that if we have questions, we can type them in the Q&A box, and later on in the presentation, we'll go through those questions and we'll try to make sense out of it. So again, this afternoon, we're talking about the hypertensive crisis. And I mean, hypertension is very common. I think the prevalence that we talk about these days is about 1 in 3 adult Nigerians with high blood pressure. Yes. With an increment in prevalence of hypertension, I'm sure a lot of people see blood pressures. Myself, actually, this morning, I saw someone with a blood pressure of 240 or 132, absolutely, and he had absolutely no symptoms. So hypertensive crisis is a problem. And I think I would, first of all, go to the first case discussion. And that's a patient that we saw, I think that was a couple of months ago. That was a 48-year-old man, Mr. Hassa. He presented with complaints of chest pain that started 24 hours before presentation. The pain is described as heaviness in the chest. The severity score was about 10/10, and it was associated with some breathlessness, which was worsened by exertion and relieved by rest as well. He had some nausea and vomiting, but no cough, no diaphoresis. He had some leg swelling, palpitations, and there was no intermittent claudication as well. And at presentation, he was conscious and alert and in some painful distress. The pulse rate was 92 per minute with some ectopics, and the blood pressure was 118/72, respiratory rate 18 per minute with some bibasal crackles. No, don't go to the next slide there, just leave that there. Would that qualify for an hypertensive emergency, Dr. Olalekan? Okay, thank you very much. Yeah. Like you said, hypertension is a very big problem in our environment and worldwide. And with some changes in the trend that we're seeing recently, absolutely, the body is actually increasing a lot in the developing country more than the developed country. So going through the case we've just presented, and by the time we'll now be talking about what hypertensive crisis is. First, there will be a severe elevation of the blood pressure. Absolutely. And so looking at this case with presented BP of 118/72 millimeter of mercury, just looking at that blood pressure, this will actually not qualify as a case of hypertensive crisis as such. Okay, can you go to case 4? Let's see the other case now. Case 4. Okay, so let's present another patient now. Let's look through this and we'll compare the two cases now. Now, this is Mrs. Osho, a 37-year-old Nigerian with hypertension that was diagnosed 5 years earlier. She came with almost symptoms that are similar to the first patient I described. He had fatigue, dyspnea, some autopnea over the last couple of days. And on arrival at the hospital in the emergency room, the BP was 250/160 millimeters of mercury. And examination, yes, they had some of S1 and S2, but she had both mitral and tricuspid regurg murmur. And a urinalysis was done, which showed some proteinuria, but the electrolytes, urea, and creatinine were absolutely normal. Thank you. Now looking at this case now, even though they had a lot of similarity in the presentation, this woman, this 37-year-old woman, will now be qualified to be labeled as someone with hypertensive crisis. And we can now go further to say, okay, is this just a case of an hypertensive urgency or hypertensive emergency? This differentiation will be made shortly as we go on. But looking at the blood pressure, like I said, for someone to be defined as being in hypertensive crisis, or what some authors also define as acute severely elevated BP, the blood pressure will be at least in the grade 3 level of blood pressure. If we are using the WHO ISH classification, that means the systolic blood pressure will be at least 180 and above, and the diastolic blood pressure will be at least 110
and above. As we'll find out later, the absolute value sometimes may not be important. The rate of increase might even be more important in some patients.
If a patient presented with such symptoms that we mentioned, that is, a patient presenting with shortness of breath and some chest pain, and would we think that what would draw our attention that this patient's blood pressure can actually be severely elevated? What would you see that you know that this person's BP is likely very high?
Okay, the first thing to say, like we usually say, is for most people, hypertension is asymptomatic.
Absolutely.
So we first of all know that this patient, even with this severely elevated blood pressure, might actually be asymptomatic. But for those that will present with symptoms, we have some general symptoms that we can identify. Most people presenting with headache,
okay,
blurring of vision.
Yeah.
Some people might have epistaxis.
Yeah.
Some people might have chest pain or palpitation, but those are general symptoms that anyone can present with.
So from what you're saying, I'll say that if this patient's blood pressure was not checked at that visit, maybe someone just said, go and do malaria test. That means the diagnosis can be missed. Okay, can we go to the next slide, please? Of that patient that's presented with what Dr. Olalekan has termed to be able to pass for hypertension emergency. So I can see that in this patient, a urinalysis was probably promptly done, and it showed 2+ of protein, even though the UCR was normal. What would your take be on that regarding this kind of situation?
Okay, doing urinalysis, because once you identify a patient with this level of blood pressure, now you want to determine, is there any affectation of any end organ, which we call hypertensive mediated organ damage. And so, and the organs you want to look at, you want to look at the heart, look at the kidney, look at the heart, look at the brain. So you want to see. And so doing a urinalysis in this patient with 2+ of protein in the urine is an indication that there may be an affectation of the kidney in this patient.
Absolutely.
And so this patient now will not only pass for hypertensive crisis, but most likely having an hypertensive emergency.
Okay, so even though the UCR was normal, we went ahead to do an ECG for the patient as well. And the ECG did show features of left ventricular hypertrophy and some tachycardia. We also went further to do an echocardiogram for the patient after the patient was stabilized, which shows features suggestive of hypertensive heart disease, and even the ejection fraction was actually reduced to some extent. So before we go deep into this hypertensive crisis of a thing that you're talking about, what is hypertension actually? Because I think we sometimes still struggle to define what hypertension is. What is this hypertension?
Okay, thank you. Hypertension, defining clinically, is that level of blood pressure at which offering treatment for the patient offer a significant gain in preventing complication and avoiding side effects from medication. So it is that level of blood pressure which places an individual at increased risk of developing cardiovascular complication. And if you treat, the person is going to benefit a lot. But for the sake of defining, that is why we now put a figure to it that, okay, when someone presents to you with persistent elevation of blood pressure, taking into consideration now the office reading, systolic 140 millimeter mercury and above, and diastolic of 90 millimeter mercury and above, we can define that as hypertension. But studies have shown that even as low as systolic blood pressure of 115 millimeter of mercury, there is some degree of cardiovascular complication. But for the sake of epidemiological definition and for uniformity in saying, okay, I'm managing a stage 1 hypertension, stage 2, that is why the figure is put at 140/90 millimeter of mercury. And for office BP, you have to have at least more than one reading of that. And For out of office measurement, as you will see on the next slide, where we have the definition based on out of office measurement, if you do a 24 hours blood pressure assessment, if the next slide, if the daytime average BP of a patient is greater or equal to 135 millimeter of mercury over 85, that person has hypertension. If the nighttime average BP is greater or equal to 120 over 70, and if the average 24 hours BP is greater than 130/80, that is using an ambulatory BP measurement that defines hypertension.
Basically, with the ambulatory BP measurements, the threshold for defining hypertension is much lower. And even for home readings as well, the threshold is much lower. Because sometimes some people get blood pressure at home that is significantly lower than the hospital, and they try to now use that 140 over 90 cutoff at home to interpret their BP, could be not so appropriate. Would you say there has been any updates in the way we define or cutoff hypertension in the last 5-10 years? Any particular updates?
There's been some changes, especially going the American Association way, trying to bring down what we used to define then as pre-hypertension. And why they are doing this, like I said, that even as low as systolic blood pressure of 115, there's some evidence of some target organ damage. So the American Heart Association and the Joint National Classification bringing the threshold down, I think that we can actively start taking active measure among these people that we use to term pre-hypertension. So bringing that level down now actually increased the prevalence of hypertension, because going by a studies done recently by Okubadejo et al. Using the old 140/90, the prevalence, like we said, like 1 in 3. But now using that lower classification, in some population, especially in some urban center, the prevalence was as high as close to about 45%. So, but the aim of doing that is not to scare us with figure, but for us to quickly take action. This action might not just be pharmacological, it could be lifestyle modification and not just drug. But even at that level, significant presence of target organ damage may necessitate you starting medication for that patient as at that stage.
Okay, so I think you've already given us some idea about how common high blood pressure is in Nigeria. So I won't bother to go into that into more details. Okay, but how does one go from becoming either a non-hypertensive person to become someone that has hypertensive crisis, or how does someone that has maybe just basic hypertension that was either acquired or something before develop a crisis? How does this happen?
Okay, thank you. A lot of factors have been identified as a possible reason why someone with seemingly maybe controlled hypertension now suddenly develop hypertensive crisis with that severe elevated blood pressure. And number one thing on the list is poor drug adherence. And when we talk about poor drug adherence, most of the time we tend to look at it from the angle of the patients. But we also should look at it also from the angle of the physician. From the angle of the physician, if you prescribe a drug that a patient cannot afford, there is no way the patient is going to adhere. That's number one. Okay. Number two, the pill burden. That is why latest guideline advocates use of combined pill that reduce pill burden and improve adherence of patients. So instead of giving patients 5 drugs, you can actually combine at least 3 or 4 of the drugs in a single tablet. That improves the adherence.
So apart from poor adherence, what other things are the things that commonly precipitates this going into the crisis?
Dietary indiscretion can large intake of sodiums in terms of salts, anxiety, presence of secondary causes of hypertension or head organ problem. Like for example, one of our patients that we had problem with this kind of problem had severe renal dysfunction. So patients with renal dysfunction, patients with hyperthyroidism, patients with adrenal disease, some of them have all this major increase in their level, in the level of blood pressure. Then drug interaction. There's some drugs that the patient will be on for other comorbidities that can spike this sudden elevation in the level of blood pressure. And for people using illicit drugs, cocaine, amphetamine, and all those stuff, and as common as drugs for colds, over-the-counter drugs for cold can also precipitate this level
of vasoconstriction.
Yes, because of vasoconstriction, drug interactions, and
okay. So I'm aware that the types of hypertensive crisis include what we call hypertensive urgencies and hypertensive emergencies. I want you to tell us briefly what, number one, is the difference between hypertensive urgency and an emergency, because I know that people many times still get this mixed up. That's one. And then briefly, the pathophysiology of hypertensive crisis. What are the key mechanisms involved before I think we go into more details?
Okay. What we need to distinguish between emergency and crisis is to look for the end organ damage in patients with severely elevated blood pressure.
Okay.
And so it is one of the lessons we want to pass here, that just measuring the blood pressure and finding it high is not the end of managing or assessing our patients. We must actively look out for those end organs. So your assessment of someone with blood pressure, with hypertension, is not done. It's not completed until you have done a fundoscopy to check the high. You have checked the heart, doing your ECG, your echo. You have checked the kidney, doing your urinalysis. You might need to do 24 hours urinary collection to check for protein. It is not done until you do all this investigation. You might need to do chest x-ray. You might need to do the blood work to be able to assess the presence of an acute or ongoing target organ damage. Let me be clear in this aspect. A patient might have had a previous end organ damage and it is not acute at present. It is not ongoing. That patient will at that point qualify to be called a patient with hypertensive urgency. But if there is an ongoing end organ damage, then that patient has hypertensive emergency. And this is important because of the way you're going to address this issue. And the fact that we said hypertensive urgency, a lot of mistake is done in this area, because we hear urgency, we say, oh, this blood pressure must come down. No, and that takes us into the pathophysiology, because the pathophysiologic problem we have here is destruction of the autoregulatory mechanism in most of this end organ damage. This autoregulation system is there so that when you have fluctuation in level of blood pressure, you are still able to maintain a constant blood flow, a stable blood flow to any of these organs. So perfusion pressure is not altered when you have maybe sudden change in BP either to the higher side or to the lower side. And this autoregulatory system keeps this blood pressure stable over a wide range of figure. But when you have this sudden or this elevation of the blood pressure that overwhelms this autoregulatory mechanism, what happens is there is increase in the mechanical shear pressure of the blood vessel. So this leads to vascular damage, endothelial damage. You now have increased permeability, you have platelets going there, you have inflammatory mediator in place, now leading to vasoconstriction and occlusion of this blood vessel, now leading to ischemia of all these end organs. And some author has also said, identify the role of the renin-angiotensin system in the development of this, that renin-angiotensin system also plays an important role, also contributing to the vasoconstriction and ischemia. And so this is why we need to know this, because it also comes into play when managing, because in this group of patients, because of that autoregulatory mechanism, their normal level is set at a relatively higher level. So if you rapidly crash the blood pressure below the lower limit of that autoregulatory mechanism, you cause another level of problem because you cause hypoperfusion in those organs. So that is why we need to be aware of this autoregulation, both in the diagnosis and also in the management of patients with hypertensive emergencies.
Thank you very much for shedding that light on the pathophysiology. I think before we go on, I think we'll take a poll. Let's go to the first poll for today. I think that's poll 6. Poll 6. And then let's participate in this poll, please. So there's a question. Is the poll launched? Okay, so the question reads, if it's 1-year-old one with hypertension of 10 years duration, but referred for with difficult to control hypertension, she had a stroke 6 months ago with residual hemiparesis. Serum creatinine done 2 weeks before that presentation was also elevated. At the clinic on that day, the blood pressure was 210/122 millimeters of mercury. Which of the following is true? A says this is an hypertensive urgency. The other one says this is an hypertensive emergency. The third one says the patient has chronic kidney disease. The last option says all of the above. Let's see how people vote. Please, let's participate.
Very good question.
Let's participate in this before we go into the clinical features of hypertensive crisis. Okay, I think in 5 seconds time you can stop it. Wait for 5 seconds. Okay, thank you for participating in the poll. So the vast majority of people felt that this is an hypertensive emergency. Next, some people say that this is an urgency. Dr. Olalekan, what do you think about that?
Okay, like we said, there must be evidence of an acute or ongoing end organ damage. So if we take the recent elevation in the level of serum creatinine as an acute thing, this patient has hypertensive emergency. But the people that went for hypertensive urgency, they are not totally wrong. They may say, okay, have you done another AIU today? Is the serum creatinine still elevated? The fact that there was stroke 6 months ago, okay, that was a past event, but we can argue on the line of this serum creatinine that, okay, if we do one today and the serum creatinine is now normal, the urinalysis is normal, okay, you can say, okay, this is an hypertensive urgency. But to me, 2 weeks elevation of the creatinine.
Will 2 weeks pass for acute ongoing? I think that's a question.
It will pass for an acute ongoing end organ damage. So I will go more for hypertensive emergency for this case.
For this case, okay, I think that's fair enough. I think, but the key thing we want to emphasize there is that you can stop sharing the result of time. The key thing we want to emphasize there is that the end organ damage that we are referring to in hypertensive emergency has to be acute and not has to be ongoing. And like Dr. Olalekan said earlier, if it's something that has happened in the past, and maybe the patient has established chronic kidney disease, for example, that will not necessarily pass for acute or ongoing. So we saw the way the patients who presented earlier presenting with some cardiovascular symptoms, chest pain, some breathlessness and co. What are the other symptoms that the patient with hypertensive crisis can present with?
Okay, thank you. The presentation will be determined by the organ that is affected.
That's if it's an emergency, right?
That is if it's an emergency. But the key thing to all is the severely elevated blood pressure. And so it's a lesson that once a patient steps into the hospital, the least we can do is to check the blood pressure, whether there are symptoms or there are no symptoms. So then, like I said, now depends on the organ involved. And we put a lot of the systemic infection there. You can have neurologic affectation. The slide before this one, neurologic affectation, cardiovascular affectation, kidney, the liver in forms of HEP syndrome, the hypertensive retinopathy, in pregnant women presenting as preeclampsia or eclampsia, aortic dissection is there. So it depends on what organ is involved. But generally, most people, like we say, present with neurologic symptoms first, and followed by cardiovascular presentation.
So the neurologic features that we often see include things like a stroke,
hypertensive encephalopathy,
and then the cardiopulmonary syndromes like a myocardial infarction or a acute pulmonary edema,
aortic dissection.
Absolutely. Okay, thank you very much for that. So if I see a patient that has what appears to be with very high blood pressure and I suspect that this could be an emergency, maybe I'm the medical officer on duty And I'm actually tempted to bring down that big report because I listened to this presentation and I said that, okay, wait, first of all, calm down, doctor. Is this an emergency or an urgency? And I'm trying to define that. What kind of workup should we do for this patient? Usually, generally speaking, I know that most patients with emergencies usually will have one symptom or the other. They may not have, but usually they'll have one symptom or the other. But how should this patient be worked up? What evaluation should we do for them?
Okay. A quick, specific, targeted history should be taken, as in towards those, for those that don't have obvious symptoms. But for those that have obvious symptoms pointing towards the system, we should still take a quick history. Like the person with acute pulmonary edema, history of difficulty with breathing, edema, cough, all those should be taken. Then history of hypertension, drug history, dietary history, history targeted and looking at precipitants should be taken, which is very important, because if you don't address that, you might actually not be able to do anything for the patient.
So what investigations are the most investigations that we
have? So having done that, now is to now look out and ascertain the end organ damage that you have, because that is going to affect the way you're going to manage this patient, because there are some general management and there are some target organ specific management. So if you don't identify that and you just treat generally, for some cases, there might be problems. So key test to identify potential causes, fundoscopy is important, is compulsory.
Many doctors don't know how to do
fundoscopy. So this is one of that we need to go back and relearn that skill. It's for most of us. ECG is very, very important. Fundoscopy will tell you whether the patient has retinopathy, whether stage 3 or stage 4. ECG will help you identify hypertrophy, identify patients with myocardial infarction or acute coronary syndrome.
Absolutely.
The full blood counts, because some can just present with low platelet count, what we call hemolytic microangiopathy, low platelets, and a lot of schistocytes in the peripheral blood film. So that is important. To assess for the kidney, you need to do the E and U. Then other specific tests, as listed on the slide, will also help you. But those key tests must be done for you to identify and know what target organ damage you are looking for.
Okay, thank you very much. So let's say, going back to the first case that we presented, a woman that presented with very extremely high blood pressure and came with what looks like an acute pulmonary edema. And let's say that I have decided that this is an hypertensive emergency and we need to treat it as such. How should the BP be reduced?
Okay.
What amount of BP goal should I reduce? Should I try to just get it from that 260, 130? I can't remember the number I was there. Should I just try to get it to 120, 80 so that when the save is over, how can we do this safely if the patient is an emergency? And of course, you help us compare to how it should be done if it was just an hypertensive emergency.
Okay, for a patient with hypertensive emergency, managing the BP is divided into two. There's a general management of the blood pressure, and there's some organ damage specific treatment of hypertension. For the general management of the hypertension, within the first hour, the aim is to reduce the blood pressure to between 20 to 25% of the mean arterial blood pressure. And if you remember the autoregulation that I talked about, this is like the limit that will not push the patient to the hypoperfusion end of the organ involved. So that is the rationale behind the 20 to 25%. So our aim for general management of the blood pressure is not to bring the blood pressure down to the seemingly normal figure, even in patients with urgency, but to gradually bring this blood pressure. Then within the second hour to 6 hours of admission, to achieve systolic blood pressure not lower than 160 and the diastolic blood pressure not lower than 110 millimeter of mercury.
Now we're talking about emergency here.
Emergency here.
So a patient has aortic dissection, a patient has a hemorrhagic stroke. I'm just using as an example because the other kind of stroke we don't necessarily touch. A patient has acute pulmonary edema. The way we bring down the blood pressure is just exactly as it's described now. Within the first hour, Usually in those kind of conditions, the patient needs to be in an ICU.
Yes.
The patient preferably we prefer to use intravenous antihypertensive in this case. Why? Because we can titrate it precisely, and of course, if we think that the blood pressure is almost getting lower, then we can always step it off, and the blood pressure will start to stabilize. So that's actually very important. And of course, I'm not asking us to, if you're not quite sure whether you're dealing with an urgency and emergency, it's better to discuss with somebody that knows better, so that you get a clarification. Because often, if we treat an urgency as an emergency, we can cause more harm than the good we are doing. Yes. So basically, you describe the blood pressure about what we achieve in the first hour. We achieve over the first 6 hours. The first 6 hours. Remember that 6 and 160. First 6 hours usually for emergencies, for true emergencies. You don't want the systolic to be less than 160. Now, we should also put in mind that most of the very high blood pressures you're going to see are going to be urgencies. Most of them are not emergencies. So we should be careful, and sometimes it can be a tricky line to distinguish. But for most cases, it's actually fairly clear-cut. So I'll just ask you that I'll give the example of the hypertensive emergency we mentioned hypertension and encephalopathy, but let's talk about hemorrhagic stroke, for instance, now. And I want you to compare. Okay, so before we go into that, for hypertensive urgency, how should the BP be controlled? So, for example, the patient I saw this morning, whose BP was like that, about 240/135, he did not have any acute ongoing endocrine damage. I listened to his heart, I did an ECG for him, he had a urinalysis done and a few other tests. There's nothing acute that is ongoing. How should that patient be managed?
Okay, for a patient with urgency, there's a flow chart that we have. But the first thing is, after ruling out all those endocrine damage, you need to confirm the blood pressure. So the person came 250/120. Okay, sir, I would like you to rest somewhere for a while, maybe between 30 minutes and 1 hour.
Absolutely.
And check the blood pressure. For some people, by the time you check the blood pressure might have actually come down a bit. Yeah. So we are not in a hurry, though it is urgency, we are not in a hurry to just rush. So let the patient rest for a while, check the blood pressure again. So after checking the blood pressure again, if the blood pressure is still elevated, what you really need to do is, after assessing adherence, all those stuff, precipitants, is to adjust the patient's present medication. Because you have to look at, because some of these things might actually be due to physician error. Maybe inadequate dosage, poor combination. So you address those issues and you allow the patient to take the drug, and you ideally you don't need to admit a patient with hypertensive urgency.
Okay, well, I would say that it's still a good precaution to at least admit and observe for a couple of hours.
A couple of hours to see that the blood pressure is actually going down. Then you can ask the patient, okay, see me the following morning. Let me see how the blood pressure is going. And we should please know, like I said, oral drugs. In hypertensive urgency, the use of parenteral medication, we don't really need that.
No, we don't.
We don't really need sublingual nifedipine for this group of patients, either emergency or urgency.
I say a lot of that, and that's in fact, some people are slammed hydralazine or something that can crash the BP and can actually cause a watershed infarct stroke. So for urgencies, usually you just need to adjust the medication or add a new medication for the patient. You may admit to observe for a few hours and see that the blood pressure is going down, and then usually that gives the patient the best outcomes. But if the patient just has an urgency and then we wrongly crash the BP, we can get deleterious outcomes. I think we should take the last poll for this segment of the crisis before we go to resistant hypertension. That'll be poll 7. Please, we can type our questions in the Q&A box. We'll address them at the end of this presentation. So the question reads, a 67-year-old man admitted with sudden onset weakness of the right side of the body and inability to speak. It's not a non-hypertensive, but his admitting BP was 210/108 rather millimeters of mercury. Which of the following is true? We can go through the options. Please, let's participate in this poll.
Okay, I can see that people are making good attempts.
Okay, try. Let's participate, please.
This is good. We'll also talk more about this in the second session. Okay, let's stop in the next 2 seconds. Okay, I can see you can end the poll. Let's see. Okay, most people went for the first option that in most patients with acute stroke, blood pressure reduction is not indicated. Okay, now this will make me to explain what I mean by the general management of the blood pressure and some specific target organ damage management of the high blood pressure. In this patient that we use for this poll, this is a patient with stroke. Mm-hmm. Now, we have to distinguish which type of stroke are we dealing with. That's number one. Is it hemorrhagic stroke or ischemic stroke? Because the way you're going to manage the blood pressure is different. If it's ischemic stroke, you need to look at, okay, if it's ischemic stroke and you don't have plan for thrombolysis, then you don't do anything to the blood pressure in that acute phase, except the blood pressure is greater than 220 over 110 or 120 millimeter of mercury, or the mean arterial blood pressure greater than 145 millimeter of mercury. Okay. But if it's a patient that you are planning to do thrombolysis for, the blood pressure needs to come down below 180, 110, because blood pressure greater than that is a contraindication for thrombolysis. But if the stroke is hemorrhagic, a recent guideline told us that you have to bring that blood pressure down so that you don't keep expanding the hematoma and the hemorrhage. So that's one of the exceptions to the general.
Absolutely. So we need to know the kind of end organ damage that we're dealing with, and the treatment has to be tailored towards that specific end organ damage. Thank you very much for adding that component in. I think that we've had a useful session on the hypertensive crisis part, so I think we should delve into resistant hypertension now. Can we go to the slide case report on hypertensive, on the next case reports? Just scroll down, please.
While he's trying to do that, let's quickly mention that in hypertensive emergency, your patients will most likely be in ICU, and we need intravenous rapid-acting medication that has short duration that you can quickly adjust.
Which ones are typically used?
Typically in our environment, let's talk about the ones that are available. Labetalol.
And even globally, I think labetalol is one of the most widely used intravenous antihypertensive agents. I think it has a very good safety profile, and it's quite efficacious. And so I think it's a very good one to use.
Hydralazine is available too, but it has an unpredictable effect on blood pressure control and also cause some rebound tachycardia. So we don't usually advocate the use of hydralazine. So, and labetalol is readily available.
I need to reinforce that that has to be done in a very strictly monitored setting, preferably ICU setting, that there's a one-to-one nursing ratio, so that the blood pressure can be, and of course the patient needs to be on a continuous blood pressure monitor, such that you know how the blood pressure is doing per time. So let's go to this second case report now. So this person here is a 60-year-old lawyer that presented with persistent high blood pressure, despite apparently good compliance with medications. And as at the time he presented, he was on 5 medications actually: nifedipine 60 milligrams in the morning, 30 milligrams at night, valsartan and hydrochlorothiazide 30 over 50 milligrams daily. That's quite a bit. Spironolactone 50 milligrams daily and metoprolol 50 milligrams daily. As at the time he presented, the blood pressure was 168 over 110 millimeters of mercury, and the heart rate was 118 beats per minute. Irregular, so there were quite some ectopics, and the sternal hedge was even also on examination. Just given this initial information,
let's go back to that slide.
Given this initial information, what do you think about this?
Okay, the first thing that I want to identify is the number of medication this patient is using.
Yeah,
we can see the patient is taking almost about 5 medications and despite that, the blood pressure control
Was poor.
And looking at this, based on the number of drugs, this will not even be a resistant hypertension. This will even go for what we call a refractory hypertension, because by the time we define the resistant hypertension, we will know what qualifies to be identified as a resistant hypertension. But this patient, a lot needs to be done to see what is going on. At least we must establish that good compliance that we talked about in this patient. That we must we must establish well, and we must also look at for other factors that might still be making this patient to have this level. Is there still an underlying cause that we have not been that we have not treated? Maybe issue with thyroid, maybe issue with diet, maybe some other drugs that is affecting the performance of this medication, because these are quite a bit, and even at relatively higher dose.
Okay, let's progress with the case report, please. He had an ECG done which showed some tachycardia and some premature ventricular contractions, and the echo showed severe LVH, and with quite reduced ejection fraction, it's 26%, and the mean arterial blood pressure was elevated. The end diastolic ventricular pressure was also increased, and of course the pulmonary artery was found to be dilated on the echo as well. The laboratory tests showed that the renal function was actually indeed impaired, like we suspected, and the creatinine was 3.9, and he had 2 plosives of protein.
So, like I said, now there is a background complication that is making the blood pressure control very, very difficult. And until this is addressed, then so this patient has most likely maybe an ongoing acute or chronic CKD, has heart failure with pulmonary hypertension. So there are a lot of comorbidities that is making the blood pressure control a lot difficult, despite the number of drugs the patient is taking. So these are things that we must take into consideration before we say a patient has a resistant hypertension, or as we may have it, a refractory hypertension.
Okay, I will just mention here that we should also put in mind that in this kind of case, the hypertension can worsen the renal condition. In fact, can acutely be worsening the kidney condition, and we know that people with CKD can have blood pressure that can be quite difficult to control. So let's start talking about the resistant hypertension now. So how do we define resistant hypertension? The fact that someone has a blood pressure that is difficult to control, does it mean that that person has a resistant hypertension?
No. We only say someone has a resistant hypertension when you have poor BP control in a patient that is taking at least 3 blood pressure medication. One of these medication must be a diuretic at the maximum tolerated dose. So, for example, a patient on nifedipine, atenolol, and methyldopa having a poor blood pressure control does not strictly qualify for resistant hypertension, because out of the 3 drugs, there must be a diuretic, and the drugs must have been taken at the optimal dose or the maximal tolerated dose for the patient. So those things must be in place before you can say someone has a resistant hypertension. And for black, the International Society of Hypertension strongly recommend that in your combination there must be a diuretic, and preferably a thiazide-like diuretic.
I think I totally agree, and we know that in blacks particularly, diuretics are quite powerful antihypertensive agents. So how common is resistant hypertension? How common would you say? Is it a very common thing?
About 3 to 4% of patients with hypertension, we have resistant hypertension, and we must be careful before we label them, because some might actually be a fake resistant hypertension, a pseudo-resistant hypertension, and not a true hypertension. But the prevalence of patients with true resistant hypertension is about 13%. I said 4%. So we have to rule out pseudo hypertension, and pseudo hypertension most of the time is usually due to white coats effect or improper measurement of blood pressure.
Especially people that are particularly pink, in which
the cup size
may not be the best for them. So, I mean, we talked earlier about the risk factors for hypertensive crisis. What would you consider to be the things that make someone more likely to have a hypertension that could be resistant?
The number one is, like I said, the issue of the drug. And maybe let me quickly mention that there's some common risk factors. Resistant hypertension is common in Black, in people that are obese, elderly people, people with end organ damage, kidney disease, diabetes, and left ventricular hypertrophy. So now going to precipitant. Number one is drugs. One, are you giving the right combination of drug? Are you giving the appropriate dose of medication? Is the patient taking this medication due to all the factors we talked about? Dietary influence also comes into play. Intake of large amount of salts. Concomitant use of drugs that could affect your blood pressure control, like we talked, all those drugs we talked about, over-the-counter drugs, patients on other kind of drugs, steroid, and all those. Those are the common things. Then end organ damage, like we identify in our patients.
I'll tell you that from my own experience, many of the patients that are found to have a blood pressure that is terribly difficult to control, actually those guys with chronic kidney disease. I think many of the BP medications actually work via the kidney to try to, excrete sodium and then to do many other things. And by the time the kidney function is impaired, it can be quite difficult to control that blood pressure. And the thiazide-like diuretics are not particularly effective in people that have fairly advanced kidney disease. Please, what are the common mistakes that people make when they are measuring BP? Because I've seen a lot of people that they measured something from somewhere, and then by the time I check the BP in my office,
what is this one? So we need to take our BP very well and correctly too. So, like we mentioned earlier, one common mistake is the cuff size. A patient told me, okay, when I want to measure my BP at home, I'm a big one for my cuff, so I used to hold it with my hand. You can never get the right blood pressure using that. So appropriate cuff size, appropriate setting. The patient should be comfortable, should be well seated. The temperature of the room should be very nice. Extreme of temperature affects blood pressure is fact-based. So the patient must be comfortably seated. Allow the patient to sit for about 5 minutes. Both feet on the floor, the back rested, and the arm rested on a table, not the arm dangling or this way.
Yeah, right. I see that a lot.
And apply the appropriate cuff. The examiner should not talk. Let's go to the next slide. I think there's a picture of that. The examiner should not talk. The patient should not talk. Then the patient must also have avoided alcohol, smoking, at least coffee, things that will affect the blood pressure about 30 minutes before that, and you take your blood pressure. Then another thing is you're doing an office blood pressure measurement, like you said. You may need to do multiple measurements, especially for patients you are seeing maybe for the first time. So you need to do multiple measurements and take average of this measurement, and you may need to do in both arms and in more than one.
And when there are issues of confusion, of course, we should know that there's ambulatory blood pressure measurements
that can sort out
those kind of issues. What are the common mistakes that people make with the combination of medication that they give a patient?
Okay, like you said, inappropriate combination. I've actually seen a patient using 2 drugs from the same class. Patient using amlodipine and nifedipine. That's number one. using multiple drugs from the same class.
Okay.
You only have no side effect and without any beneficial effects. Number two, inappropriate combination, like we said for black, the use of thiazide diuretic
or thiazide-like
or calcium channel blocker is very good. So using drugs like amlodipine or lamivudine combined with any of these thiazide diuretic is an appropriate combination in black. Then when you have some compelling indication, a patient with diabetic, patient with proteinuria, in those kind of patients, using ACE inhibitor or angiotensin receptor blocker can be helpful. Patient with palpitation, beta blocker, but right combination of drug and appropriate dosage.
Absolutely, and appropriate dosage escalation
yes,
as well.
Because physician inertia, a lot of us are afraid to actually increase the level of. You have seen someone taking nifedipine 20 milligram BD for almost 6 months and the blood pressure is not changing. And we are saying resistant hypertension.
Dr. I tried not to preempt the slide. So the next part we're talking about, which has already been shown on this slide, is if we see patients, you mentioned earlier that many patients don't adhere to the therapy. And from your experience, what are the common reasons that you've seen why patients don't use their medication? What are the very common reasons for that? Because I think that's one of the top reasons why people's BP are not controlled. Actually.
Yes. The first one is some patients are not even buying the drug because they could not afford it. Okay. So the cost of medication. So we must take into consideration the purchasing power of our patient. And that's why after making a diagnosis, we have to involve our patient in the management. There's no point writing a drug that a patient cannot afford for him.
Absolutely.
Then sometimes the instructions are not clear.
Yeah.
Amlodipine take once daily.
Yeah.
Nifedipine use twice daily. Captopril use twice daily. But the patient might not be clear. The instruction might not be clear. Maybe from you or from the pharmacist. So at the end of the day, the patient goes up and starts using your nifedipine maybe once every two days or every three days. So education is important, and involving the patient in the plan is very important. Some people will not adhere because of side effects.
Because of fear of side effects.
Some fear of side effects.
Then some real
side effects. Okay. Someone gave me. We had a colleague, if you remember, I said, the first time they gave me amlodipine, the headache was so bad. But this same patient, this same colleague, by the time he was going home, he left on the and it's been fine since then.
I think sometimes we forget to warn our patients the kind of side effects that can happen, and telling them of the kind of side effects that will likely resolve. So by the time they know and they're expecting it, can make it better, first of all. And then beyond that, many patients actually, we should communicate with them that if they experience something that they are unable to tolerate, they should come back, we'll change it for them. But if we don't give them that option and that information ab initio, they will just pack our medication somewhere and maybe start some about treatment or something. What are the other common reasons that you see why patients don't take their drugs?
Other reasons apart from compliance is drug-drug interaction.
Yeah.
And we're in the era of supplements, herbal preparation, and some of these things actually affect the efficacy or absorption of blood pressure drugs. Concomitant use of other drugs that lead to fluid retention, like non-steroidal anti-inflammatory drugs, or other drugs like antihistamine, decongestant, steroids, and a lot of all these drugs that affect absorption of some of this medication. So a lot of things need to be taken into consideration. So when you are managing your patient, we should not only focus on our antihypertensive.
Yeah.
We should also take a history of other comorbidity, other medication that these patients are taking that might actually affect the overall control of the BP. So we should manage our patients as a whole, not just looking from the keyhole of my own is just blood pressure. I'm not concerned whether it's on the oral contraceptive pill, whether it's a patient with sinusitis, or whether it's a patient with other condition that needs steroids. So I'm not bothered.
Absolutely. And of course, I know we see some patients sometimes, some patients taking excessive alcohol, for example, or patients with obstructive sleep apnea, especially patients that are peak. Even though for this patient as well, it's important to still control the blood pressure while we tackle whatever factors that appears to be contributing to the blood pressure being difficult to control. What would you say is the role of secondary hypertension in this kind of blood pressures that are difficult to control? Which ones do we see now and then?
Presence of thyroid illness, both hyper and hypo, Cushing syndrome, background kidney disease, pheochromocytomas, all these are associated secondary causes that could make the blood pressure poor, despite good compliance on all you've done the right combination, the patient is taking well, you're given optimal doses. So what else is happening? Okay, let me ask for a thyroid function test. Let me do early morning cortisol let me measure the vanilla mandelic acid. These things to us, we think they are not happening. But by the time you see this patient, you discover that these things are actually there. And if you don't address them, if you like give the patient 5-6 drugs, the blood pressure will not go down.
Okay, I think we're out of time now. I will just ask you to just guide us. I think you have an algorithm. Guide us just through the stepwise fashion to evaluate someone that presents with what looks like a resistant hypertension. Next.
So the first thing, let's say here, the first thing you want to do, exclude resistance.
Yeah.
So you may need to do an ambulatory blood pressure monitor for this patient to be sure, because the patient might just be having a white coat aggravation of the BP.
Okay.
Number 2, make sure that you have measured your BP right.
Appropriately.
Number 3, look out for issues that affect adherence, whether from the patient side or from your side. Then make sure you give the right combination. Look out for other complication, drug interaction. Then when you've done all this, then you might now need to add an extra medication to your medication. I'm going to the next slide. From a study, the pathway 2 study, most of these patients have been found to have a lot of salt accumulation, fluid accumulation. So the use of mineralocorticoid receptor antagonists, spironolactone, has been found to help a lot in patients with resistant hypertension. So once you have ruled out all these other factors and your patients are taking all these drugs, then you may now need to start your patients on a spironolactone. And I was not surprised the patient I presented had spironolactone as part of the medication. So the patient was at the level of resistant hypertension and spironolactone was added, but despite that, the blood pressure control was still not good enough.
I think we've had a good afternoon in this. We've had a good afternoon today, and I think as you've gone to talk about most of the aspects of the resistant hypertension we need to talk about, we're out of time. We want to go through questions now. But the last thing I'll mention this afternoon is that the accelerated hypertension, which has been used frequently in the past, does it still has a relevance using that term in today's medicine?
Using terms like accelerated hypertension, malignant hypertension, all still comes under hypertensive emergency. In the past, the word malignant accelerated hypertension is just used to like substratify patients with hypertensive retinopathy. So using accelerated hypertension as patients not having more than grade 3, not having more than grade 3 level of hypertensive retinopathy. And by the time the patient has a papillary edema, that's a grade 4 hypertensive retinopathy, we say the patient has a malignant hypertension. But now, once patient has evidence of retinopathy, whether at the level of grade 3, as a soft exudate, or papillary edema, the patient needs to be managed as a patient with hypertensive emergency.
Okay, thank you very much. Thank you very much, Dr. Olalekan. Let's start taking the question now before we take a break and go for the next session of the presentation. So I'll read the question out. The first question here reads, what is masked hypertension and how can we diagnose it? We didn't talk about this.
We didn't talk about that. The masked hypertension is like the opposite of white coat hypertension. So a patient has a normal blood pressure in the office, but out of office, the patient has high blood pressure. How will you know this? When you see a patient in the office with seemingly normal blood pressure, but significant presence of head organ damage. You see someone with 110, 60, whatever, having left ventricular hypertrophy, a lot of, you wonder what's happening. And the only way to confirm that is to do an ambulatory blood pressure measurement. So ambulatory blood pressure measurement will help you to identify patients with white coat hypertension.
Okay.
We help you to identify patients with masked hypertension. We help you to identify some patients that fall into what we call non-dipping, or because you know the normal pattern of blood pressure is your blood pressure should be going down by the day. So in the evening, your blood pressure in the evening should be lower than morning. But you have some people having nocturnal hypertension and you can only get that when you do ambulation. So there are a lot of things we will gain by telling some of our patients to do ambulatory blood pressure.
Thank you very much, sir. So someone else is asking here that if we have to wait for investigations like a 24-hour urinary protein before determining an urgency or emergency, won't it lead to waste of time? I think I'll just clarify that myself. That's one of the investigations that can be a further investigation. But if we're looking for proteinuria in a patient with hypertensive, in someone with very high blood pressure, we just do a dipstick urinalysis that will get results within a few minutes. So quantifying proteinuria in someone that has maybe 2 or more plots of proteinuria is just an additional investigation that can wait till later. Someone asked here that what's the role of the HEMA-BP, that's the mean arterial blood pressure, in managing hypertensive emergency?
That is very important, especially in patients with stroke, like I talked to you about. That in ischemic stroke, you need to look at the mean arterial blood pressure before you intervene. Like I said, for those that you are not planning for thrombolysis. But for those you are planning for thrombolysis, you must bring down the blood pressure below 180, 110. So you don't even need to wait for MEP in that class. But for people that you are not planning for thrombolysis, looking at the mean arterial blood pressure is important. Once it's above 145, you want to intervene and reduce that blood pressure, like I said, between 20 to 25 of that mean arterial blood pressure within 1 hour. You are not talking about crashing or bringing in that to 120. When you do that, what you do is you now widen the umbra and make the deficit worse.
Okay, someone else is asking that a patient with a stroke and elevated blood pressure, is it an hypertensive emergency, whether ischemic or hemorrhagic? The answer is yes, it is an hypertensive emergency. But the target blood pressure or where we want the blood pressure to be in the 2 different situations are just different. So someone with a ischemic stroke and a blood pressure of 180 over 115 is an hypertensive emergency. Okay, but I don't need to. And that's why what Dr. Olalekan said initially is very critical. We should define the hand organ damage as important. So if it's an ischemic stroke, I will cause more harm than good by reducing that blood pressure to 160 over something, except if I was planning to thrombolyze. And I know that thrombolysis for stroke is actually not something that is routinely done in this environment. Even globally, maybe less than 5% of stroke end up getting thrombolysis. So there's a question here about the rule of bringing down the BP. Does it also apply to patients with diabetes? Okay, so I'm not clear about the context of that question. Okay, but the way we manage hypertensive emergencies, hypertensive urgencies is not different in any way for patients with diabetes. Yes. Even though for hypertension generally, we tend to want to treat people with diabetes perhaps with a lower target, and we have a lower threshold for treating someone with diabetes for high blood pressure.
That target, you can achieve that after bringing the patient out of that crisis state.
But in the crisis state, the target is just like for everybody else. Is sublingual nifedipine contraindicated in the case of hypertensive urgency?
Yes.
Sublingual nifedipine is contraindicated at all times, generally. In fact, there's a strong FDA warning against using sublingual nifedipine. So it's not something that we should use under any circumstance, actually. Well, I'm aware that some doctors still do it, but it's not recommended because it can bring down the blood pressure erratically, and we end up causing more harm than good. So there's another question here for you, Dr. Olalekan. What medications are to be used in hypertensive emergencies to achieve reduction in blood pressure that is not too rapid?
That is not too rapid. Yeah, the person should use the word hypertensive urgency. And like I said, what we need to do is still the routine drugs that the patient has been taking. We might need to optimize the dose. We might need to do better combination. We might need to look into adherence.
We may need to add to it.
Yes.
We may need to observe the patient for a while. But once it's an urgency, there's no need to bring it down rapidly. But if it's an emergency, then we may need to bring it down rapidly. Sometimes, but that depends on the situation. And I think that we mentioned that the IV medications like IV labetalol has an advantage for that, in that you can easily titrate it, but it's something that has to be done in monitored setting, ICU setting, a patient on continuous blood pressure monitoring, and we must not bring down the blood pressure by more than 25% within the first hour or so of presentation. How do you manage the patient with varying blood pressure in both arms to the tune of 10 to 15 millimeters of mercury, and what's the cause of this phenomenon?
Okay, if you have a blood pressure difference between 10 to 15 millimeter in the arms, this is still normal. So you can have that variation. But when it is higher than that, there could be some aortic coarctation, dissection of the aorta, some psychiatric arthritis, and some of these, whatever.
And it is said that people that have differential blood pressure reading in both arms should prefer to use the arm with a higher reading. Okay, so someone asked which other drug can be used apart from labetalol in hypertensive emergencies. The normal oral antihypertensives can often be used. The IV can be used as an addendum. In Nigeria, the main IV that is available is labetalol, which has to be used carefully, I would emphasize. But apart from that, in other climes, they have nitroprusside, metoprolol,
felodropam, esmolol,
okay, so there are quite a bit of them, but they're not routinely available, and then you may not be familiar with its use. It's better to use something that you're very familiar with the use of it. Clinically, how can you distinguish between hemorrhagic and ischemic stroke? I will answer that very fast. You cannot distinguish clinically. Yes, we have the CIRAT score and many other scores, but they're not so reliable, and you cannot swear by it, and you cannot give aspirin or thrombolyze or do anything based on
maybe the person who is looking at symptoms, okay, headache, vomiting, seizure, all those things that we point more towards hemorrhagic symptom-wise, but until you do
the imaging, you can't tell definitely.
You can't tell definitely.
So someone asked here that in hypertensive urgency that we mentioned that it is not necessary to reduce the BP, for example, with nifedipine. Does this apply in all cases? You had a patient with a blood pressure of 240 over 130 with no evidence of endocrine damage. So I think this person misunderstood something.
We've not really said you should not bring down the BP. What we're saying is the reduction needs to be done gradually over maybe 2-3 days. You are not in a hurry to achieve the so-called normal, because the autoregulatory level for this patient is already set at a relatively higher rate. So if you give your sublingual nifedipine, you might actually cause more harm. So you can use your nifedipine, not the sublingual nifedipine. You can use oral form of nifedipine and other medication. And like we said, you may need to still admit your patient. We didn't say they should go.
It's better to admit, actually.
Admit and observe. Admit and observe.
And the BP will go down gradually. So someone say, can the BP cuff be placed on the forearm for a cuff size that is unavailable in an obese patient? The reading will be unreliable. I can tell you that very easily.
Where is the forearm?
Forearm is here. It will be unreliable.
Where
you feel the pulse there. Maybe they'll use the pulse. I'm not even sure. It's not going to be reliable. It's not going to be reliable. So usually you need to find the cuff. And when Abuja here, a lot of people are quite big. And that means in hospitals, you need to have cuffs of different sizes. If you're in an environment where you cannot get labetalol for hypertensive emergency, what should you do? I'll leave that for you, Dr. Olalekan.
What should you do? The first thing I will say is, one, you have to make use of what you have.
Absolutely.
That's number one thing. But you might have some challenges, especially maybe if the patient is unconscious and cannot take other drugs. So you may need to still pass NG2. Give what you have.
Yeah.
Then I will advise that you quickly transfer the patient to where the patient can be appropriately managed.
The problem with oral agents can be used for these people, but the problem is the BP can go lower than you want, and then exactly you'll not be able to fine-tune all those 25% you said, because it's easy to say, but sometimes it can be quite tricky. The next question.
For diabetic,
is it safe to use moderatic with a slightly low potassium? Well, for patients who has scroll down. For patients who has low potassium, usually we are wary of using a diuretic, but when you use them, then we should monitor the potassium. If it starts to go low, we should give them potassium supplementation, either just dietary or we give them Stoke in addition to their medication. is it compulsory to take for patients to take their hypertensive daily? And when the BP is not controlled, is there when the BP is controlled, is there a role for alternate day medication take?
I see that a bit. Antihypertensive are to be taken daily.
Okay, so I think that's the summary for that.
Yes, and when the BP is controlled, adjust the drug.
Absolutely.
Because by the time you are doing alternate day, you are just encouraging poor adherence.
And you are going to encourage chaos. The medication are designed to work for about 24-hour period, and you are going to be having more daily fluctuations of the BP in patients that are taking their medications every other day, every 3 days, and that's not really good for the endocrines as well. Someone asked if calcium channel blockers and thiazide are safe compared to ARB or ACE inhibitors, considering the effect of the RAS on all the options that I mentioned there are safe. CCBs, thiazide lights, and ACE inhibitors are safe as well. Someone mentioned here that does anxiolytic have a role in the management of hypertensive crisis? Anxiolytics like Lexotan, I see that a lot.
Yes, like one of the persistence we talked about, anxiety is there.
Okay.
So that might be one of the reasons for you to admit your patient with hypertensive urgency, to allay their fear. To calm, especially when something has happened recently in the environment, maybe somebody collapsed, somebody died from. You see a lot of people coming, so the anxiety, so you might need to calm them down, admit them, reassure them, use anxiety.
Absolutely. Unfortunately, we won't be able to answer the remaining of the questions live, but we'll try to answer the question in the chat box later on. We really thank you. We appreciate your questions, but we don't want to drag the second session for too long. It's already 5:21 now. So we'll take a few minutes break, maybe about 3 minutes break. And then when we come back live, we'll start to have the discussion on stroke management. Here with us, we already have a consultant neurologist here, and I think it will be a beautiful session, and let's stay tuned. Thank you.